Thank you, Joanne. I don't know how I'm going to top that, although you talked about fear, frustration, and anger. You had a couple of other nouns in there, and I sort of live with all those. So that's a possible starting point. I want to sort of tie the excellent conversations that have been going on all day here into my remarks by just making a couple of observations that I hope people don't find unfair. But I did the arithmetic during the day. I've been involved with PACE for 40 years, and I take particular pride in the fact that the legislation establishing PACE as a permanent Medicare benefit and as a permanent state plan option was enacted while I was administrator, with a lot of work on my part as well, of course, that many other people. And I continue to be involved with PACE in a variety of ways, and as frustrated as everyone else by the continued slow growth. But I was thinking today, even if tomorrow, overnight, we could increase enrollment in PACE by a factor of 10, we'd still be talking about a fraction of all the folks who are duly eligible and in need of that level of comprehensive care on a regular basis, and we'd still have a whole big chunk left over to address. I also, without meaning to be unfair or single anybody out, I was listening to the description of the Capable program, which I think is great and is almost identical to a program my wife was hired to work on in 1983 in Greenwich Village in Manhattan. That was then called the Chelsea Village program and involved a nurse, not an occupational therapist, but a social worker and a handyman, doing many of the same kinds of things that Capable does, and is no longer in existence for a variety of institutional reasons. And then the whole conversation this afternoon reminded me of something I've said on a number of occasions, and I don't know if Gail's going to want to comment as well, but I was administrator of the Healthcare Finance Administration for 1,571 days. As the old joke goes, who's counting? But who's counting? Why you count. And there wasn't one of them that went by that somebody didn't come up to me with an idea that they were sure was going to save Medicare a lot of money. And there are some things that save Medicare. Pardon?
And since then.
And since then. There are things that save Medicare money. Gail and I may disagree about this. The thing that most effectively saves Medicare money is reducing payment rates to providers. Everything else saves Medicare money in the right kinds of circumstances and ends up costing more money when a lot of third-rate providers get in and don't target the patients they serve as carefully as the programs we've heard about today, and tend to be more concerned with short-term returns than with the quality of services they're doing. And it's very, very hard for CMS or anyone else to tell the difference at the entry point of the program of a new provider, of what category they're going to fall into. So trying to move from there to a somewhat more general set of points, and conscious of the time limits, and that's towards the end of the day. Let me just make two major points with two subsidiary points, one subsidiary point for each. The first major point is thinking about not only how many good things are going on out there, but how many of them sound familiar, because I've seen things like them in a variety of communities over the last 40 years, suggests to me that what we have here fundamentally is an institutional failure, a policy failure to design or support or address the kind of institutions that are necessary at the community level to ensure that these kinds of services are available to the people who need them, and that they're good programs and they're sustainable programs, and they perform in the way they should. In fact, the burden of this stuff has fallen increasingly on two sets of organizations that I would argue are particularly ill-qualified to do them. The first are hospitals, which are the last people you want running community-based services or integrating with community-based services. That's a whole, and I say that as somebody who works for hospitals and is a board member of hospitals and has grandchildren born in hospitals and so forth. They do a whole bunch of very good things very, very well, but running community-based services is not among them. And there are some very profound and I think not easily altered reasons why that. The other people who now are increasingly institutionally responsible for providing community-based long-term care services are managed care plans. Some of them Medicaid managed care plans that were coerced by their state to get into the long-term care business, a few of them specialty long-term care plans. And I don't think, however, that they're going to be in a position to do the kinds of things we want and expect because, in fact, as opposed to the experience with managed care in Medicaid and to a lesser extent in Medicare, there's not a whole lot of water in the payment streams at the moment to be squeezed out. In fact, I would argue that most Medicaid long-term care in most states in the fee-for-service mode is underfinanced. So that if you start with that as the basis for a capitated program and expect people to be able to maintain service levels, let alone innovate and involve new contractors or develop and learn how to do new things and so forth, once in a while you get lucky, but I don't think it's going to be systematically available. And I hope Kathy isn't offended, but there are some small number of communities in which AAAs could do that job, could be the integrated, and there are a few in which are trying, in San Diego, for example, to a lesser extent in Pittsburgh, but the average agency there doesn't have the capability or the resources, and they've all been starved financially for the better part of the last decade. So we need to figure out, and Joanne's right, it won't always be the same institutional model in the same community, but we need to figure out who's going to be responsible, and not just for the Medicaid enrollees, but for everyone who can afford to pay the full cost of community-based long-term care, which is most families and most individuals. The subpoint of that, however, is that, well, we got to get hospitals out of the focal point of this delivery system. The people we're talking about are very ill and have very complicated medical problems, and the quality of their medical care is still central to their well-being all of the time they're in the system. And so we need to figure out not how to run a system without doctors and without specialists and without sophisticated inpatient things and without pharmacists, perhaps more importantly than all the other professions. We need to figure out how to integrate that, and that again is an institution building problem, I think, that we have a long way to go on. Having said that, we're still going to need more money because Medicaid is, I actually spoke to the director of the Association of State Medicaid Directors the other day and say, well, you know, we're in the boom times now because the economy's been good and all the new money of the ACA in a lot of states, but we're already expecting it to end. And now we have, in many of our states, competition from public education that we haven't experienced in the last number of years as we've eaten up all the new revenue. And teachers are finally fed up with that, and they want their share of it as well. It's not unfair to say, and I say this as someone who was once responsible for this and with a lot of friends in the process, that under the legal and political constraints under which most Medicaid programs operate, when budgets are tight, their only available strategy in dealing with long-term care, realistically, because either through the instrumentalities of managed care or in a fee-for-service world, is to cut back on the enforcement of quality standards. That's been a consistent pattern throughout the 50-year history of Medicaid financing of long-term care services, and that's not an outcome we want. I don't think there's Medicare, you could get all the Medicare savings from all the projects you want, that's not going to fill the gap in terms of the growing need. So we are going to need, as Joanne said, some new ways to pay for this. And I would, before, however, starting to talk about particular ways to pay for it, I would point out what has been a consistent implicit theme, although only raised once or twice directly in the course of today's discussion, that when we talk about social determinants of health, we're talking about other contributors to the well-being or lack of well-being of households and individuals, all of which have suffered from reductions or freezes in public expenditure over the last 2 decades. So that the general shortage of publicly available funding is greater, I would argue, for the social services than it is in the Medicaid covered long-term care services. And I don't see in the current immediate political environment where the revenues are going to come from. They're not going to come from the families themselves because, as Joanne pointed out, they're going to have less available resources in the future than they have at the present. And last point, we talked appropriately a lot today about family caregivers and other so-called informal caregivers and their role and how to support them. But as I think all of you know, the ratio of adult children to people in need, old people in need of long-term care, has passed its all-time historical peak in the United States and is going to fall continuously over the next 20 or 25 years. Because there are so many of us baby boomers, and because we were so much smarter than our parents about not having lots of children, maybe because we looked around at one another and decided it wasn't they hadn't had such a good idea. But whatever the reason is, so per X number of people who are going to need these services, a higher proportion of them are going to require paid caregivers. And I don't have enough time for my speech on how we're going to start having to treat paid caregivers like human beings, but it's going to be, even at current inadequate levels of compensation of paid caregivers, it's going to cost us a whole lot more money. And if we start paying them appropriately, it'll cost even more than that. So we got a hole, and I don't hear any conversation of how to fill it.
With that as a base,